Welcome to the deep dive. We're here to break down complex source material, really getting into the foundational knowledge you need to perform at that elite professional level.
That's the goal.
Today, we're tackling a big one, pediatric central nervous system disorders. It's an incredibly demanding field.
It really is.
And our mission today is genuine mastery, going beyond just lists to really understand the why behind the clinical patterns, the pathophysiology.
Absolutely. And it's uniquely challenging, isn't it? You're dealing with brains that are still developing rapidly. Symptoms can be incredibly subtle. They change all the time.
And the stakes are so high.
Exactly. The window for intervention can be really, really short.
Oh.
So for you listening, to get to that elite level, you need diagnostic precision across this whole spectrum.
Right. Recognizing the slow burns, the chronic stuff.
And spotting the acute crises like infections, stroke, plus understanding all the congenital issues, the electrical disturbances like seizures.
Yeah.
It's a lot.
We've got a solid stack of sources, really covering the core of this specialty. We'll be unpacking, everything from tiny genetic changes to big structural problems.
All the way to the really tough end-of-life decisions, like diagnosing brain death and those very specific criteria.
Okay, let's jump right in. Part 1, the foundational diagnostic toolkit. Starting with the absolute bedrock, history and localization.
Couldn't agree more.
So the pace of symptom onset, the tempo, as you said, that's often the biggest clue right off the bat in pediatric neurology, isn't it? How things progress tells you so much.
It's huge. It really helps triage things immediately. Let's take acute onset. If the symptoms are absolutely worst right at the very beginning, maybe they get a bit better after that initial hit, but boom, worst at the start.
What does that scream?
Vascular event. You have to think stroke, hemorrhage, something like that. An immediate, instantaneous insult to the system.
Okay. What if it's acute, but maybe developed over a few days? Not quite that instant lights out scenario.
Right. So it's still fast, but not that fast.
Right.
That shifts your thinking more towards an acute inflammatory process or an infection.
Like meningitis or encephalitis.
Exactly. Bacterial meningitis, viral encephalitis. Our sources also mention things like ADEM, acute disseminated encephalomyelitis. The symptoms build quickly, maybe over hours or days, but they weren't maximal in the first second.
Okay, slowing it down now. What about a subacute onset? We're talking weeks here.
Weeks.
Yeah.
That time frame makes you think of something that's, growing or maybe spreading persistently. A serious infection that's brewing.
Like TB meningitis.
TB meningitis is a classic example. Or maybe a fungal infection, a brain abscess. It could also be certain types of brain tumors that grow relatively quickly.
So fast enough to cause symptoms, but slow enough that the body might try to compensate for a little while.
Precisely. It's not the immediate catastrophe, but it's definitely building momentum.
And then the really long timelines. Months, years, or maybe those cases where kids get worse, then better, then worse again.
Right. So chronic progressive, that slow, steady downhill slope over months or years that really points towards degenerative disorders. Neurometabolic diseases are high on the list, or maybe very slow-growing tumors.
And the back and forth pattern.
That's the relapsing remitting course. And seeing that pattern is incredibly helpful diagnostically. It really narrows things down.
Like multiple sclerosis.
MS is a key one, yeah. But also certain metabolic diseases, or maybe an intercurrent illness like a simple fever, triggers a metabolic crisis and causes a sudden worsening followed by some recovery. That up and down cycle is the clue.
What about developmental history? If the concern is more about milestones, how does time factor in? Is it just what level they reached or how they got there?
It's definitely about the change in the age of that change. We're looking for developmental regression. Did the child always seem delayed across the board? That might suggest something congenital, an early genetic issue.
Versus losing skills they once had.
Exactly. Do they learn to walk and talk and then suddenly lose those skills?
Yeah.
Sudden, rapid regression might point to an acute insult, maybe one of those metabolic slurs we mentioned, or an infection.
Whereas a slow, gradual loss of skills
points you much more strongly towards those progressive, often lysosomal degenerative disorders. That timeline, that history, it dictates your immediate workup. What tests you order first?
Okay, makes sense. So we've got the time dimension. Now let's shift to space localization of lesions, using the physical exam to pinpoint where the problem is.
Yes, and this is where good clinical skills really shine, guiding your next steps, especially imaging. The fundamental distinction we have to make is upper motor neuron versus lower motor neuron, UMN versus LMN.
Remind us of the key differences there. Where do they originate?
Okay, so the UMN pathway starts above the anterior horn cell in the spinal cord. So cortex, the descending tracts like the corticospinal tract, internal capsule, brainstem. The element involves the anterior horn cell itself, the nerve root coming out of the cord, the peripheral nerve, the neuromuscular junction, and the muscle.
And clinically, how do they present differently? Tone and reflexes.
Tone and reflexes are the big ones. UMN lesions typically cause increased tone spasticity and exaggerated brisk deep tendon reflexes, them tight muscles, jumpy reflexes.
And LMN.
LMN is the opposite. You get decreased or absent tone, flaccid weakness, muscle wasting or atrophy, and crucially, early and complete loss of reflexes in the affected area. You might also see fasciculations, those little twitches under the skin.
Okay. But even within UMN problems, the location really matters. Our sources mention that classic cross-paralysis with brainstem lesions. Can you unpack that?
Yes, that's pure neuroanatomy in action. Think about it. The main motor tracts cross over low down in the medulla, but the cranial nerves, controlling the face, eyes, etc., they exit the brainstem above that crossing point.
So a lesion on one side of the brainstem.
Will knock out the cranial nerve function on the same side that's an ipsilateral LMN-type cranial nerve palsy. But it hits the motor tracts before they cross, so you get weakness in the limbs on the opposite side of the body, contralateral UMN signs.
Ipsilateral face-eye weakness, contralateral limb weakness, that's the cross pattern.
Exactly. Finding that is a powerful localizer, often pointing right to the brainstem, maybe a small stroke or tumor there.
What if the UMN lesion is higher up, say, in the internal capsule, that dense bundle of fibers?
Right. The internal capsule packs all those descending motor fibers into a really tight space. So a lesion there, like a stroke, often causes a very dense, complete contralateral hemiplegia weakness of the entire opposite side of the body.
Affecting arm more than leg sometimes?
Often, yes, the sources note that. It just reflects the specific arrangement of fibers in the capsule. It tells you the damage is in that critical white matter highway, causing widespread functional loss.
And if the damage is actually in the spinal cord?
Okay, so below the level of the spinal cord lesion, you'll see paralysis, paraplegia, or quadriplegia, depending on the level. But the really key detail is at the level of the lesion itself.
What happens there?
Right at the segment where the cord is damaged, you often get LMN signs, flaccidity, loss of reflexes, because the anterior horn cells or nerve roots at that specific level are directly hit. Then below that level, you transition to the classic UMN signs of spasticity and hyperreflexia because the descending control pathways are cut off.
That mix of LMN at the level and UMN below is characteristic.
Very characteristic of a spinal cord injury.
Now, I want to circle back to something you mentioned, the nuance with acute UMN lesions. We usually link UMN to spasticity, but the sources say an acute stroke might initially cause flaccidity. Why is that?
Yeah, that's the phenomenon often called spinal shock or cerebral shock. The sudden, massive insult to the upper motor pathways can cause a temporary, widespread shutdown of function below the lesion.
So it looks like an LMN picture initially.
For a short time, yes. You get flaccidity and loss of reflexes. It's only later, sometimes days or weeks, as the spinal cord circuits below the lesion recover but are now free from higher control, that the typical UMN spasticity and hyperreflexia emerge. It's a potential pitfall if you examine someone only in that very acute phase.
Good point. Okay, shifting back to LMN signs, what specific physical exam findings help us localize the problem outside the spinal cord in the nerves or muscles?
Well, one classic sign is the Gower sign. You see this in kids with proximal muscle weakness, typically from a myopathy like Duchenne muscular dystrophy.
How does that look?
The child has trouble standing from the floor. They have to use their hands to push off the floor, then walk their hands up their own legs to get upright. That tells you the hip and thigh muscles are weak.
Right. What about neuromuscular junction problems, like myasthenia gravis?
The key there is often the pattern of weakness across the day, the diurnal variation. Especially weakness of the extraocular muscles, causing droopy eyelids or double vision, or pharyngeal muscles causing trouble swallowing.
It gets worse later in the day.
Dramatically worse. As the day goes on, the neuromuscular junction fatigues because of the underlying defect, like antibodies blocking acetylcholine receptors in myasthenia. That worsening weakness with activity or late in the day is a huge clue, often pointing you to the diagnosis even before you do specific tests. Hashtag 2. Investigations and imaging technologies.
Okay, so localization helps point us, and then we need investigations. If you suspect a CNS infection, the lumbar puncture, the LP for CSF analysis is often critical. But let's hit the big safety issue first. When do you absolutely not do an LP straight away?
This is non-negotiable. You defer the LP if there's any suspicion of significantly raised intracranial pressure or a mass lesion causing midline shift.
Why is that so dangerous?
Because if you pull CSF fluid out from the spinal space when the pressure inside the skull is very high, you can create a pressure gradient. This can cause the brain tissue, particularly the brainstem, to herniate downwards through the foramen magnum.
Which is potentially fatal.
Instantly fatal, yes. So if the patient has clear focal neurological signs, papilledema, swelling of the optic disc, or their consciousness is rapidly declining, you need to get imaging, usually a CT scan, before you even think about the LP. Check for mass effect first. Safety first.
Okay. Assuming it's safe to proceed, what are the normal CSF values we're comparing against? What should it look like?
Normal CSF should be crystal clear, like water, colorless. Under the microscope, you should see very few white blood cells. The standard cutoff is usually less than 5 lymphocytes per cubic millimeter. No neutrophils.
And protein, sugar.
Protein should be quite low, typically in the range of 20 to 40 milligrams per deciliter. And CSF glucose should be roughly 2/3 of the blood glucose level measured at the same time. That ratio is important.
So deviations from that immediately raise flags.
Big flags. Cloudy or turbid fluid, thousands of white cells, especially neutrophils, high protein, low sugar, maybe less than 40% of blood sugar. That pattern screams bacterial meningitis.
And we can do more specialized tests on CSF now too, right?
Yeah. Oh, yes. Molecular diagnostics have been a game changer. We routinely run PCR polymerase chain reaction to look for the DNA or RNA of specific microbes. Super important for diagnosing viral infections like herpes simplex virus, HSV, or enteroviruses quickly.
What else?
We can measure things like myelin basic protein. If that's elevated, it suggests active breakdown of myelin, pointing towards demyelinating diseases like MS or ADEM. And increasingly, CSS lactate is measured. High lactate can be a clue towards certain neurometabolic disorders, particularly mitochondrial problems.
Okay, let's talk imaging. Starting bedside, ultrasonography. Where does that fit in for pediatric neurology?
Ultrasound's big advantages are that it's portable, relatively cheap, and uses no ionizing radiation. Its main use, though, is pretty much limited to newborns and young infants whose fontanelles, the soft spots, are still open.
What can you see well?
You get a decent view of the ventricles, fluid spaces, and the brain tissue immediately around them, the periventricular white matter. So it's good for spotting things like intraventricular hemorrhage, which is common in preemies, or hydrocephalus in large ventricles.
But limitations.
Big limitations. You don't see the surface of the brain, the cortex, very well. You can't really assess the temporal lobes adequately. And critically, it's very poor for visualizing the posterior fossa, the cerebellum and brainstem, because the sound waves don't penetrate the bone well back there. And lots of important malformations occur in the posterior fossa.
So that naturally leads us to CT versus MRI. CT is often the first line in emergencies. What's it good for, and where does it fall short?
CT is fast, it's everywhere, and it's relatively inexpensive. Its strengths are visualizing calcification, which you see in some infections like CMV or toxoplasmosis, or in conditions like tuberous sclerosis, and detecting acute bleeding really well. If you suspect a bleed, CT is usually the quickest way to see it.
Yeah.
Significant downsides for detailed neuroanatomy. As we said, it struggles with the posterior fossa due to bone artifacts. It's not great for the temporal lobes, which are common sites for seizures and infections like HSV. And importantly, it's poor at showing subtle details of myelination, which is crucial in assessing development, and it often misses neuronal migration disorders. Plus, it uses ionizing radiation.
So MRI steps in for that finer detail?
Exactly. MRI provides much better anatomical detail, superior soft tissue contrast, and crucially, no ionizing radiation. It's the gold standard for assessing myelination patterns, looking for subtle structural abnormalities like cortical dysplasia or other migration disorders.
And those views.
Yes. MRI easily gives you coronal and sagittal views, which are essential for looking at midline structures, the corpus callosum, the pituitary gland, the brainstem, and those tricky temporal lobes. If you need detailed structure, or if you're looking for inflammation, infection, congenital abnormalities, or vascular issues without obvious bleeding, MRI is generally the way to go.
Okay, finally in this section, the genetics piece. It's advancing so fast. When you have a child with, say, intellectual disability, especially if they have other unusual features, we're looking beyond the old standard karyotype now. We're talking about copy number variations, CNVs. What are those, basically?
Think of the genome like a huge set of encyclopedias. A CNV is like having a chunk of pages, or even a whole volume, either missing a deletion or accidentally duplicated. These changes involve chunks of DNA sequence, bigger than single-letter changes, but too small to see on a traditional chromosome test.
And finding these CNVs is becoming more common.
Much more common, thanks to newer technologies. Our sources compare the yield. Older, targeted tests like MLPA might find a CNV causing the issue in maybe 5 to 10% of kids with unexplained intellectual disability.
But chromosomal microarray,
Chromosomal microarray, or CMA, is much more powerful. It looks for CNVs across the entire genome simultaneously. For intellectual disability, especially if there are other features like birth defects or unusual facial features, CMA can find a definitive genetic cause in up to 20% of cases. It's really become a first-tier test in that situation.
And the next frontier is sequencing.
Absolutely. Next-generation sequencing, NGS, allows us to read the entire genetic code, or at least all the protein coding parts, whole exome sequencing, looking for tiny single-letter changes, single nucleotide variants that cause disease. This is pushing diagnostics and precision medicine forward incredibly quickly.
Okay, moving from the diagnostic foundation to specific conditions, let's tackle seizures and epilepsy. We know about 5% of kids have a seizure in the first few years, but the immediate, life-threatening emergency is status epilepticus SE. The definition, particularly the timing, is critical here.
Absolutely critical. The traditional definition was, a seizure lasting more than 30 minutes or multiple seizures back-to-back without recovery, but clinically that's way too long to wait.
What's the modern approach?
The working definition, the point where you need to act as if it's SE, is much shorter. Any convulsive seizure lasting longer than 5 minutes should be treated aggressively as impending status epilepticus. Don't wait for 30 minutes.
Why the urgency? What's happening in the brain during prolonged SE?
That continuous, uncontrolled electrical storm puts immense metabolic stress on the brain cells. You get excitotoxicity, energy failure, inflammation. It's incredibly damaging. This cascade can lead to multi-organ problems, significant long-term neurodevelopmental problems, and even death. The mortality rate is around 10%. Time is brain, quite literally here.
So that 5-minute mark triggers a specific management protocol. Can you walk us through the sequence?
Right. First things first, always. Airway, breathing, circulation. Get oxygen on. Check glucose. Then at that 5-minute mark, you hit first-line therapy. That means a fast-acting benzodiazepine.
Like lorazepam.
5-lorazepam is often preferred if you have access. If not, rectal diazepam or buccal intranasal midazolam are good alternatives. You can often repeat the dose once if the seizure continues after another few minutes.
Okay, benzos first. If that doesn't stop it, we're maybe 10-20 minutes in now.
Now you move to second-line therapy. This is typically a non-benzodiazepine eighth anticonvulsant. The classic choice is IV phenytoin, or its prodrug fosphenytoin, which is a bit safer to infuse.
And if that fails, seizure still going despite benzos and phenytoin fosphenytoin.
Now we call it refractory status epilepticus, RSE. This is a serious situation. You need to be thinking about escalating care, potentially to the ICU, and starting third-line agents.
What are the options there?
Common third-line choices include 5-valproate, favipiravir, or maybe 4-phenobarbital. The choice might depend on the patient's age, underlying cause if known, and local protocols.
And then there's the really scary scenario, super refractory SE.
Yes, that's defined as SE continuing or recurring despite 24 hours of treatment with a continuous anesthetic infusion, like midazolam or propofol or pentobarbital. Basically, you've thrown the kitchen sink at it, including inducing a coma, and it's still happening. Management becomes extremely complex, often involving multiple simultaneous infusions and intensive investigation for rare or unusual causes.
A grim situation. Okay, let's shift to the most common type of seizure event in childhood. Febrile seizures, FS, affects a huge number of kids, 3–8% between 6 months and 5 years. How do we quickly tell a simple FS from a complex FS?
It boils down to 3 key features. To be called simple, a febrile seizure must meet all 3 criteria. 1, it has to be generalized, involving the whole body, not just one side. 2, it has to be short, lasting less than 15 minutes total.
Yeah.
And 3, it has to be solitary. Only 1 seizure occurs during that 24-hour period of febrile illness.
If it breaks any of those rules.
If it's focal, starts on one side, or lasts longer than 15 minutes. Or if the child has more than 1 seizure within the same illness episode, it's classified as complex. That distinction is important for prognosis and risk assessment.
Right, and this brings up an interesting debate mentioned in our sources. The link between prolonged febrile seizures and later hippocampal damage, potentially leading to epilepsy. What's the thinking now? Did the seizure cause the damage?
That was the older view that a long, hot seizure could directly injure the hippocampus, leading to scarring, mesial temporal sclerosis, and setting the stage for temporal lobe epilepsy later on. But the current thinking is often the other way around. Meaning that the child who has a prolonged, complex febrile seizure might have already had an underlying vulnerability in that hippocampus, maybe from a subtle birth injury, a genetic factor, or a prior insult. That vulnerability makes them susceptible both to having prolonged seizures and to developing epilepsy later. The prolonged seizure might be more of a marker of an abnormal brain than the primary cause of the long-term damage.
That's a significant shift in perspective. So, does that change how we think about preventing febrile seizures? Is prophylaxis needed?
Generally, no. For simple febrile seizures, the risk of long-term problems is very low, and the side effects of daily medication aren't worth it. Prophylaxis is usually reserved only for children who have very frequent recurrences.
How frequent?
The guidelines suggest considering intermittent prophylaxis if a child has, say, 3 or more recurrences within 6 months or 4 or more within a year.
And how does that work? Continuous meds?
No, it's intermittent. Parents are taught to give an oral benzodiazepine like diazepam or clobazam as soon as the child develops a fever and continue it for the first, say, 2 to 3 days of the febrile illness. It's quite effective at preventing a seizure during that specific illness.
Okay. Let's talk about epilepsy itself now, using the official ILE 2017 definition, basically. 2 unprovoked seizures, or 1 seizure with a high risk of another one happening. Let's start with the generalized onset types.
All right, generalized means the seizure starts on both sides of the brain at once. The most recognized type is generalized tonic-clonic, GTC, what used to be called grand mal.
What does that look like?
It usually starts with a tonic phase, muscles stiffen, the person might cry out, lose consciousness, fall down. Then comes the clonic phase, rhythmic jerking of the limbs. Often there's tongue biting, incontinence. Afterwards, there's usually a period of confusion or sleepiness, the postictal state.
Okay. What about myoclonic seizures?
Myoclonic seizures are sudden, brief, shock-like jerks or contractions of a muscle or group of muscles. They can be subtle, just a quick head nod or shoulder shrug, or more dramatic, causing someone to drop something or even fall. They happen very quickly.
And atonic seizures?
Atonic means without tone. So these are sudden losses of muscle tone. If it affects the whole body, the person will just collapse, sometimes called drop attacks. If it's just the head and neck, you might see a sudden head nod, also very brief.
Then there are absence seizures, the ones that used to be called petit mal. How do those present?
Absence seizures are brief episodes of scaring spells, like the person just zones out. They stop what they're doing, stare blankly, maybe have some subtle eyelid fluttering or lip smacking. The key is they're very brief, usually lasting only, say, 5 to 20 seconds, maybe up to 30-60 seconds according to some sources, and they end abruptly. The person is immediately back to normal with no confusion.
That brief duration and immediate recovery is key to distinguish them.
Absolutely. If someone is having staring spells that last for minutes or they're confused afterwards, it's much more likely to be a focal seizure, not a true absence seizure.
Okay, let's talk about those focal onset seizures then. They're actually more common, right? About 60% of childhood epilepsies.
That's right. And they often imply an underlying structural cause in the brain. They start in one specific area. We divide them based on whether awareness is affected.
So simple focal means?
Simple focal means the person remains fully aware and conscious during the event. The symptoms depend on where in the brain the seizure starts. It could be localized jerking of a limb, a sensory experience like tingling or seeing lights, or even an emotional feeling like sudden fear.
And you mentioned Todd's palsy earlier.
Yes, after a simple focal motor seizure, the limb that was jerking might remain weak or paralyzed for minutes to hours, even up to 24 hours. That's Todd's palsy. It can sometimes be mistaken for a stroke, but it follows a seizure.
And complex partial seizures, though the terminology is shifting slightly with ILA.
Right. The key here is impaired awareness. The person isn't fully conscious or responsive. These often arise from the temporal lobe and are frequently associated with automatisms, repetitive, purposeless movements like lip smacking, chewing, fiddling with clothes, or wandering around confused.
They might have an aura beforehand.
Often, yes. Especially with temporal lobe onset. That might be a rising feeling in the stomach, a sense of déjà vu or jamais vu, strange smells or tastes, or visual distortions.
You highlighted neurocysticercosis earlier as a cause, particularly relevant globally.
Hugely important etiology, yes. In many tropical and developing countries, infection with the larval stage of the pork tapeworm, Tadenia solium, is a leading cause of new-onset focal seizures in older children and adults. The cysts, or granulomas, in the brain act as seizure foci, often showing up as wing-enhancing or disc-enhancing lesions on imaging. It's a major public health issue.
Definitely something to keep in mind depending on the context. Finally, in this seizure section, the really difficult category, epileptic encephalopathies. These aren't just seizures. The epilepsy itself seems to drive cognitive decline.
Exactly. The seizures and the abnormal brain activity are actively harming development. The two classic examples are West syndrome and Lennox-Gastaut syndrome.
Let's start with West syndrome. What's the typical presentation?
West syndrome usually presents in infancy, typically between 3 and 12 months. It's defined by a specific triad. First, epileptic spasms, which are sudden, brief contractions often involving flexion or extension of the body, occurring in clusters, especially on waking or falling asleep.
Second part of the triad.
Second, profound developmental delay or regression. Kids often lose skills they had previously acquired.
And third, the EEG.
Third is the characteristic EEG pattern called hypsarrhythmia. It looks chaotic, very high voltage, disorganized, with random spikes and slow waves all over the place. Seeing that pattern is diagnostic.
Treatment.
Treatment needs to be aggressive to try and stop the spasms and maybe improve the developmental outcome. First-line options are often hormonal therapy, like ACTH or high-dose corticosteroids, or sometimes the drug vigabatrin, especially if tuberous sclerosis is the cause.
Okay. And then there's Lennox-Gastaut syndrome, LGS. When does that typically appear?
LGS usually starts a bit later, often in early childhood, maybe evolving from West syndrome or appearing on its own. It's notoriously difficult to treat.
What are the defining features?
LGS is characterized by multiple different seizure types in the same patient. They often have tonic seizures, stiffening, especially during sleep, atonic seizures, those drop attacks, and atypical absence seizures. They also usually have significant intellectual disability and developmental regression.
Is there a typical EEG pattern for LGS?
Yes, the EEG usually shows generalized slow spike and wave discharges, typically running at a frequency of 1.5 to 2.5 hertz slower than the 3 hertz seen in typical absence epilepsy. Finding that pattern along with the multiple seizure types and cognitive impairment points strongly to LGS. It's a very challenging condition with generally poor long-term outcomes. #GHAI4, neurological regression and degenerative disorders.
All right, let's pivot slightly to talk more broadly about neurological regression, that progressive loss of already acquired milestones. This often points towards inherited metabolic or degenerative disorders. You made a key distinction earlier based on the type of molecule involved. Can you elaborate on why small molecule disorders often have that relapsing remitting course?
Yeah, this is a really useful concept for thinking about these diseases. Small molecule disorders involve problems with pathways that handle things like amino acids, organic acids, or urea. Think of conditions like urea cycle defects, maple syrup urine disease, MSUD, or classic PKU.
What happens in those?
In these conditions, toxic small molecules build up in the body. This buildup often gets much worse during times of metabolic stress, like when the child has a fever, an infection, is fasting, or eats too much protein. During these crises, the toxin levels spike, causing acute neurological symptoms like lethargy, vomiting, seizures, coma, leading to a sudden deterioration.
And then they might improve between crises.
They might stabilize or even improve somewhat when the metabolic stress is removed or treated, like with a special diet. But often, each crisis causes some irreversible damage, leading to that relapsing remitting pattern, but with an overall progressive decline over time.
Okay, so crisis-driven decline. How does that contrast with the large molecule storage diseases?
Large molecule storage diseases are different. These are typically lysosomal storage disorders, like the mucopolysaccharidosis, MPS, Tay-Sachs, Gaucher disease, or metachromatic leukodystrophy, MLD. Here, complex molecules, lipids, glycoproteins, mucopolysaccharides can't be broken down properly and accumulate continuously inside the cells, particularly in the lysosomes.
So it's not usually triggered by acute illness?
Generally not. It's a slow, relentless accumulation process. The cells just get progressively clogged up and dysfunctional. This leads to a much more chronic, progressive, downhill course without those dramatic acute crises seen in small molecule diseases. The decline is steady and insidious over months or years.
And the age of onset can vary widely even within these categories.
Absolutely. Some, like infantile Gaucher disease, type 2, or early onset Crab disease, present in the first few months of life with rapid progression. Others, like Rett syndrome or MLD, might present around 1 to 2 years of age after a period of apparently normal development. And still others, like adrenoleukodystrophy, ALD, or some forms of MPS, might not become apparent until later childhood.
You mentioned adrenoleukodystrophy. Does imaging help pinpoint that one specifically?
Yes, ALD often has a characteristic MRI pattern, especially the childhood cerebral form. It classically shows progressive demyelination starting in the posterior white matter and the parieto-occipital regions, often symmetrically, and then spreading forward over time. Seeing that specific posterior predominance is a strong clue for ALD and prompts testing for very long-chain fatty acids.
Given this wide range of often devastating disorders, what's the absolute priority in the diagnostic workup for regression?
The absolute priority is to identify the treatable conditions as quickly as possible. While many of these disorders don't have cures, some do have specific therapies that can halt progression or significantly improve outcomes if started early. We absolutely must not miss things like congenital hypothyroidism or biotinidase deficiency, which are often screened for at birth but can sometimes be missed or present later. Conditions like Wilson disease, copper metabolism, have chelation therapy. PKU requires lifelong dietary management. And for some lysosomal disorders like Gaucher type 1 or Pompe disease, enzyme replacement therapy, ERT, is available and can make a huge difference. Finding these treatable causes amidst the broader category of regression is paramount.
Okay, shifting gears now to structural problems, starting with congenital malformations. Neural tube defects, NTDs, are a major group. It's remarkable that something as simple as folic acid supplementation before and in early pregnancy can cut the risk by over 70%.
It's a massive public health success story. NTDs represent a spectrum of defects resulting from the neural tube not closing properly in early gestation. The mildest form is spina bifida occulta.
What does occulta mean here?
It means hidden. The bony arch of one or more vertebrae fails to fuse, but the spinal cord and meninges are usually fine, and the defect is covered by intact skin. Often it's found incidentally on an X-ray.
Are there any outward signs to look for?
Sometimes, yes. You need to carefully examine the skin over the lower back. Look for clues like a small dimple, a tuft of hair, a red birthmark, or a fatty lump, lipoma. A dermal sinus tract little opening is particularly important
Why is the sinus tract significant?
because it can be a direct pathway from skin down towards the spinal canal, creating a risk for recurrent meningitis. If you see a suspicious sinus, it often needs imaging and potential surgical closure.
Okay, moving up in severity, meningocele.
In a meningitis, the bony defect is present, and the protective membranes around the spinal cord bulge out through that defect, forming a fluid-filled sac visible on the back. Importantly, the spinal cord itself is usually in its normal position.
So neurological function might be okay.
Often it is, but the sac needs to be surgically repaired early, usually within the first few days of life, to prevent it from rupturing and getting infected.
And the most severe form is meningomyelocele.
Yes, in meningomyelocele, not only do the meninges bulge out, but the spinal cord and nerve roots are also contained within that sac, often malformed and exposed. This is the most common and most serious type of open NTD.
What are the functional consequences?
Because the neural tissue itself is damaged and displaced, these infants almost always have significant neurological deficits below the level of the lesion. This typically means lower motor neuron paraplegia, flaccid paralysis of the legs, sensory loss, and major problems with bladder and bowel control requiring lifelong management.
And meningomyelocele often comes with other brain abnormalities, doesn't it?
Almost always. It's very strongly associated with the type 2 Arnold-Chiari malformation.
Can you remind us what that involves?
Chiari II involves downward displacement of parts of the hindbrain, specifically the medulla pons and cerebellar vermis, through the foramen magnum into the upper spinal canal. This distortion can block CSF flow.
Leading to hydrocephalus.
Exactly. About 80–90% of children with meningomyelocele develop hydrocephalus, often due to aqueductal stenosis caused by the Chiari malformation. They usually require a shunt to drain the excess CSF.
You mentioned Chiari type 2. Is there a type I?
Yes, Chiari type I is generally milder and more common. It involves only the cerebellar tonsils dipping slightly, usually defined as 3 to 5 millimeters or more below the foramen magnum. It's often found incidentally or might present later in adolescence or adulthood with symptoms like headache, especially with coughing or straining, neck pain, dizziness, or balance problems.
Yeah.
It's usually not associated with meningomyelocele.
Okay. And another major hindbrain anomaly is the Dandy-Walker malformation.
Right. The Dandy-Walker malformation is characterized by 3 main features: cystic enlargement of the fourth ventricle, complete or partial absence of the cerebellar vermis, the central part of the cerebellum, and an enlarged posterior fossa, often with upward displacement of structures. It's thought to result from abnormal development of the roof of the fourth ventricle, possibly failure of the foramina of Megendie and Luschka to open properly.
Does that cause hydrocephalus too?
Very commonly, yes. The large cyst in the posterior fossa often obstructs CSF flow, leading to hydrocephalus and sometimes a noticeably prominent back of the head, occiput.
Okay, let's move to a fascinating group where skin findings give clues to brain problems. the neurocutaneous syndromes. Let's hit the big three, starting with neurofibromatosis type 1, NF1. How is that diagnosed?
NF1, also known as von Recklinghausen disease, is an autosomal dominant condition. Diagnosis is clinical, based on meeting at least 2 out of 7 specific criteria.
What are the most common criteria?
The most classic are the skin findings. 6 or more café au lait macule, those flat, light brown spots, which need to be over a certain size depending on age. 5 millimeters before puberty, 15 millimeters after. Also axillary or inguinal freckling, freckles in the armpits or groin area. 2 or more neurofibromas, benign nerve sheath tumors, or 1 plexiform neurofibroma, a larger, more extensive type.
What about eye findings or bone problems?
Yes, Lisch nodules, benign growths on the iris, usually need a slit lamp exam to see them. An optic pathway glioma, a tumor on the optic nerve. And specific bone abnormalities like sphenoid wing dysplasia or thinning of long bone cortex can also count. Having a first-degree relative with NF1 is also one of the criteria.
So you need 2 from that list. Okay, next, tuberous sclerosis complex, TSC, also autosomal dominant. What are the key CNS issues?
TSE affects multiple organ systems, but the brain is almost always involved. Common neurological problems include developmental delay, autism spectrum disorder, and epilepsy, which can be severe, often starting as infantile spasms, West syndrome, in infancy.
What do we look for on brain imaging?
2 characteristic lesions. Cortical tubers, which are areas of abnormal brain development in the cortex, and sependymal nodules, SENs, which are growths lining the ventricles. The SENs need monitoring because they can sometimes grow and transform into a type of tumor called a subependymal giant cell astrocytoma, SEGA, which can block CSF flow.
And the skin signs for TSC, different from NF1.
Very different. The classic TSE skin findings include hypopigmented macules, often called ash leaf spots. These are pale patches that might need a Wood's lamp, UV light, to see properly, especially on fair skin. Also, facial angiofibromas, previously called adenoma sebaceum, small reddish bumps, typically over the nose and cheeks, often appearing in mid-childhood. Shagreen patches, leathery skin patches, usually on the lower back, and periungual fibromas, growths around the nails, are also common.
All right. And the third one, Sturge-Weber syndrome. This one's usually sporadic, not inherited.
That's right. Sturge-Weber is caused by a somatic mutation, meaning it happens after conception and isn't passed down. It's defined by a vascular birthmark on the face of port wine stain, Divus flammeus, typically involving the skin supplied by the first ophthalmic V1 division of the trigeminal nerve.
And what's happening in the brain?
There's an associated vascular malformation on the surface of the brain on the same side as the facial birthmark, a leptomeningeal angioma. This abnormal blood vessel network leads to poor blood flow and oxygen deprivation in the underlying brain tissue over time.
Causing neurological problems.
Yes. This typically leads to seizures, often focal and starting in infancy, contralateral hemiparesis, weakness on the opposite side, developmental delay or intellectual disability, and glaucoma in the eye on the affected side.
Is there a characteristic imaging finding?
Yes. Over time, the chronic poor blood flow leads to calcification in the cortex underlying the angioma. On imaging, especially CT scans later in childhood, this can create a classic tram track or railroad track appearance of parallel calcified lines, #6, CNS infections, and acute encephalitis syndrome, AES.
Okay, let's turn to acute threats, CNS infections, often presenting as acute encephalitis syndrome or AES. That typically means sudden fever, altered consciousness, maybe seizures or focal signs. For viral encephalitis, what does the CSF usually show?
In most viral CNS infections, the CSF typically shows a pleocytosis, meaning an increased number of white blood cells, but usually it's predominantly lymphocytes, not neutrophils like in bacterial meningitis. The protein might be mildly elevated, but crucially, the glucose level is usually normal.
We need to talk about Japanese encephalitis, JE. It's highlighted as the leading viral cause globally. Understanding the transmission cycle seems key.
Absolutely essential. JE is caused by a flavivirus, an RNA virus. It's transmitted by mosquitoes, specifically the Culex tritonuricus species, which breeds heavily in rice paddies.
And the virus doesn't just cycle between mosquitoes and humans.
No. The main amplifying hosts in nature are pigs and certain water birds, particularly ardade birds like herons and egrets. These animals get infected, develop very high levels of virus in their blood, viremia, without getting sick themselves, and then mosquitoes feeding on them pick up the virus and spread it further.
So where do humans fit in?
Humans, unfortunately, are incidental dead-end hosts. We get infected if bitten by an infected mosquito, and we can get severely ill, but the level of virus in our blood is usually too low to infect mosquitoes that feed on us.
That has implications for control, right? Vaccinating humans won't stop the cycle in pigs and birds.
Exactly. Human vaccination protects the individual, which is vital, but it does not interrupt the natural transmission cycle of the GHAI virus in the environment or provide herd immunity in the way vaccines for human-to-human transmitted diseases do. Control really requires mosquito control and potentially animal vaccination, too.
How is JE diagnosed clinically? Any specific clues?
Clinically, it causes fever, headache, altered sensorium, seizures, and often prominent movement disorders like Parkinsonism or dystonia. MRI can be very helpful.
What does the MRI show?
Classically, JE affects deep gray matter structures. MRI often shows characteristic bilateral lesions in the thalamus and also frequently involves the basal ganglia, midbrain, and pons. Seeing that pattern is highly suggestive.
And lab confirmation.
Definitive diagnosis usually relies on detecting JE-specific IgM antibodies in the CSF or serum using an ELISA test. The IgM usually becomes detectable in CSF by about day 4-7 of illness, and in serum a few days later, becoming highly sensitive and specific by around 10 days.
Okay, let's contrast JE with herpes simplex virus, HSV, encephalitis. This is the most common cause of sporadic viral encephalitis, right? Not epidemic like JD can be.
Correct. HSV encephalitis can occur anytime, anywhere. It's often caused by HSV1 reactivation. It typically presents very acutely, often with fever, headache, altered behavior, seizures, and prominent focal neurological signs.
Where does HSV tend to hit the brain?
It has a striking predilection for the temporal lobes and sometimes the inferior frontal lobes. This localization is key.
So imaging is crucial.
Yes, MRI is much more sensitive than CT, especially early on, for showing inflammation, swelling, and sometimes hemorrhage in the temporal lobes. Seeing those characteristic temporal lobe changes is highly suspicious for HSV.
In diagnosis.
The gold standard is PCR for HSV DNA in the CSF. It's very sensitive and specific, and treatment needs to start immediately if HSV is suspected, even before confirmation.
What's the treatment?
Intravenous acyclovir for at least 14 to 21 days. Early treatment is crucial because despite therapy, HSV encephalitis often causes severe neurological damage and has a high rate of long-term disability or death if treatment is delayed.
Okay, shifting to bacterial meningitis. Still a major threat. Need a high index of suspicion. What are the clinical clues, especially in infants where classic signs might be missing?
Infants are tricky. They often don't show the classic nuchal rigidity, stiff neck, or Kernig-Brudzinski signs until they're older, maybe closer to age 2. Instead, you look for non-specific signs. Irritability, lethargy, poor feeding, vomiting, maybe a high-pitched or shrill cry. The most important sign in an infant is often a tense, bulging anterior fontanelle. That's a red alert.
And in older children?
You're more likely to see the classic meningeal signs, plus fever, headache, photophobia, altered mental status. One specific sign to look for is a purpuric or petual rash, which strongly suggests meningococcemia, meningitis caused by Neisseria meningitis. That's a medical emergency.
And the CSF and bacterial meningitis, we touched on it, but let's recap the classic profile.
It's usually obviously abnormal. The fluid is often turbid or even frankly purulent, looks like a pus. The white cell count is typically very high, often in the thousands, and predominantly polymorphonuclear cells, neutrophils. Protein is usually markedly increased, and glucose is characteristically low, often less than 40% of the simultaneous blood glucose because the bacteria consume it. Gram stain might show organisms.
Treatment needs to be immediate, right? Empirical.
Absolutely immediate. Don't wait for culture results if meningitis is suspected. Start empirical IV antibiotics right away. Usually a third-generation cephalosporin, like ceftriaxone or cefotaxime, is the backbone. Depending on age and local resistance patterns, you might add vancomycin, especially to cover resistant streptococcus pneumonia. Ampicillin might be added for infants to cover listeria.
What about steroids? Dexamethasone.
Yes, dexamethasone is often recommended, particularly for suspected bacterial meningitis in infants and children over 6 weeks old, caused by Haemophilus influenza type B or streptococcus pneumonia. The key is to give it with or just before the first dose of antibiotics.
Why is it helpful?
It helps reduce the intense inflammation in the subarachnoid space that occurs when bacteria are killed by antibiotics. This reduction in inflammation has been shown to significantly decrease the risk of long-term sensorineural hearing loss, which is a common and serious complication of bacterial meningitis.
Okay, one more infectious topic. Neurocysticercosis, NCC. We mentioned it causing seizures, especially in endemic areas, up to 35% in some rural regions. Can you quickly recap the pathogenesis? How do the larvae get to the brain?
It happens when humans ingest the eggs of the pork tapeworm, Taenia solium. usually through food or water contaminated with human feces containing the eggs, not by eating undercooked pork, which causes the intestinal tapeworm. The eggs hatch in the intestine, the larvae penetrate the gut wall, enter the bloodstream, and can travel anywhere, but frequently lodge in the brain, muscle, or eyes.
And in the brain, they go through stages.
Yes, the cysts evolve through typically 4 stages: vesicular, viable larva in a fluid-filled cyst, a little inflammation. Then colloidal vesicular, larva starts to degenerate, cyst fluid becomes thicker, inflammation starts. Then granular nodular, cyst collapses, intense inflammation and edema, but also granuloma. And finally, calcified granular, scarred calcified nodule, inflammation resolves.
And seizures usually happen during which stage?
Most commonly during the inflammatory stages, particularly the granular nodular stage, when the dying larva triggers significant surrounding edema and inflammation, irritating the brain tissue. That's when you typically see the ring-enhancing or disc-enhancing lesions, on contrast MRI or CT. Sometimes you see cysts in multiple stages at once, the starry sky appearance.
Management often involves killing the cysts with antihelminthic drugs like albendazole, but the timing relative to steroids is absolutely critical.
Life-savingly critical. If you have active inflammatory lesions, usually 5 or fewer, albendazole is used to kill the remaining parasites. However, killing the parasites acutely worsens the inflammation around them.
So you need to dampen that inflammation first.
Precisely. You must start corticosteroids like prednisone or dexamethasone 2 to 3 days before initiating the albendazole. This suppresses the host's inflammatory response, preventing potentially dangerous cerebral edema and worsening neurological symptoms when the cysts die. Starting albendazole without steroid pretreatment can be disastrous.
Are there situations where you don't use albendazole?
Yes, absolutely. It's contraindicated in ocular cysticercosis because the inflammation could destroy the retina. It's also generally contraindicated in cysticercal encephalitis, where there are numerous cysts causing diffuse brain swelling. Killing them all at once would cause catastrophic edema. And usually, calcified lesions don't require antihelminthic treatment, just seizure management if needed. ###7. Stroke and raised intracranial pressure, ICP.
Okay, let's talk about stroke in children. It happens maybe more often than people think. The presentation is usually sudden weakness, worst at onset. Ischemic strokes are slightly more common than hemorrhagic, about 55% to 45%. What are the big risk factors in kids? They're different from adults, right?
Very different. In adults, we think atherosclerosis, hypertension, atrial fibrillation. In kids, you need to think about other categories. Cardiac disease is a big one, especially cyanotic congenital heart disease, which can lead to clots, or paradoxical emboli, if there's a hole like a PFO. Rheumatic heart disease is still relevant in some parts of the world.
What about blood disorders?
Hematological conditions are crucial. Sickle cell disease is a major cause of stroke in affected children. Iron deficiency anemia has also been linked as a risk factor, possibly related to thrombocytosis. And inherited prothrombotic disorders, like deficiencies in protein C, protein S, or antithrombin, or factor V Leiden mutation, increase clotting risk.
Any specific vascular problems?
Yes, underlying vasculopathies like moyamoya disease, progressive narrowing of intracranial arteries, arterial dissection, spontaneous or traumatic tears in artery walls, or vasculitis. Infections like varicella can sometimes trigger a post-infectious vasculopathy too.
We already discussed localization based on signs, cortical involvement often causing seizures or aphasia, internal capsule causing dense hemiplegia, brainstem causing cross signs. Is management different from adults? Thrombolysis.
Thrombolysis, clot-busting drugs, is much less commonly used and studied in children compared to adults. The evidence base is weaker, the time windows are often missed, and the risk factors are different. Management often focuses on supportive care, identifying and treating the underlying cause, preventing complications like seizures or swelling, and secondary prevention, often with antiplatelet agents like aspirin or anticoagulation if there's a clear embolic source or prothrombotic state.
Okay, now let's address the final common pathway for many CNS insults, raised intracranial pressure, ICP, defined as pressure consistently above 15 millimeter Hg in older children, lower in infants. What's the core problem when ICP goes up?
The fundamental issue is that the skull is a fixed box. When something inside swells or takes up space, edema, blood, a tumor, excess CSF, the pressure rises. This rising pressure starts to compress blood vessels, reducing cerebral perfusion pressure, CPP, which is the pressure gradient driving blood flow to the brain, CPP equals mean arterial pressure, ICP.
So less blood flow.
Right. Reduced CPP leads to ischemia, lack of oxygen, which causes brain cells to swell, cytotoxic edema, which further increases brain volume in ICP. You get this dangerous, vicious cycle. Raised ICP leads to ischemia, which leads to more edema, which leads to even higher ICP.
What are the clinical signs we need to watch for? How do we know ICP is rising?
Early signs could be subtle: headache, often worse in the morning or with coughing staining, vomiting, especially without nausea, blurred vision, drowsiness, or irritability. In infants, look for that bulging fontanelle, separated sutures, increased head circumference.
Any specific exam findings?
You might hear the Mace Wind sign. Tapping on the skull near the sutures sounds like a cracked pot if the sutures are split. Papilledema on fundoscopy is a classic sign, but it takes time to develop and might be absent early on. A sixth cranial nerve palsy, causing inability to look outwards, abduct the eye, is common because this nerve has a long intracranial course and gets stretched easily by raised pressure. But remember, it's often a false localizing sign. It just tells you pressure is high, not where the primary problem is.
What about the really late ominous signs?
The Cushing's reflex, or Cushing's triad, is a very late and dangerous sign, indicating severe brainstem compression. It consists of 1. Hypertension, increased blood pressure, 2. Bradycardia, slow heart rate, and 3. Irregular respirations. Seeing that means herniation is likely imminent or occurring.
Let's talk about those herniation syndromes. What happens when the pressure gets so high that brain tissue starts to shift?
It's disastrous. The brain gets squeezed from one compartment to another across rigid dural folds, like the tentorium cerebelli, or through bony openings, like the foramen magnum. There are several patterns, but 3 main ones to know.
Cursed.
Lateral transtentorial herniation, also called uncal herniation. This is often caused by a mass in one hemisphere, pushing the uncal, C, the inner part of the temporal lobe, downwards over the edge of the tentorium.
What does that compress?
Critically, it compresses the third cranial nerve, oculomotor nerve, on the same side. This classically causes a unilateral fixed and dilated pupil, blown pupil, often with ptosis, droopy eyelid, and inability to move the eye inwards or up-down. It can also compress the brainstem, leading to contralateral weakness, hemiparesis, and altered consciousness.
Okay, second pattern.
Central transtentorial herniation. This is usually caused by diffuse swelling or masses pushing both hemispheres downwards symmetrically through the tentorial opening. It causes progressive brainstem dysfunction from top to bottom.
How does that look clinically?
You see declining consciousness, initially small reactive pupils that become mid-sized and fixed, and changes in posture, starting with decorticate posturing, arms flexed, legs extended, indicating damage above the midbrain, progressing to decerebrate posturing, arms and legs extended, indicating damage at the level of the upper pons. Respiratory patterns also change.
And the third, worst one.
Transforaminal herniation, or consular herniation. This is when the cerebellar tonsils are forced downwards through the foramen magnum, directly compressing the medulla oblongata in the lower brainstem, which controls vital functions like breathing and heart rate.
Clinical signs.
This causes neck stiffness, head tilt, rapidly deteriorating consciousness, irregular breathing patterns leading to apnea, cessation of breathing, bradycardia, and cardiovascular collapse. It's often rapidly fatal.
Management of raised ICP is obviously urgent. What are the key initial steps?
First, stabilize airway, breathing, circulation. Then, positioning. Elevate the head of the bed to about 30 degrees and keep the head strictly in the midline, no neck twisting, to optimize venous drainage from the brain. Avoid constricting neckties or collars.
Then medical therapies.
Yes. Controlled hyperventilation can be used acutely as a temporary measure. Lowering the PaCO2, carbon dioxide level in the blood, to around 30-35 millimeter Hg causes cerebral vasoconstriction, which reduces cerebral blood volume and can rapidly lower ICP. But it's temporary and can risk ischemia if overdone or prolonged.
What about osmotic agents?
Osmotic therapy is a mainstay. Intravenous mannitol or hypertonic saline, usually 3% ACL, are used to draw excess water out of the brain tissue and into the bloodstream, reducing cerebral edema and ICP. Sedation and analgesia are also important to reduce metabolic demand and agitation. In severe cases, induced coma or even surgical decompression might be needed. #8, coma and brain death.
Our final section covers the most severe alterations of consciousness, coma and ultimately brain death. Coma is defined as that sustained, profound state of unresponsiveness. What causes it, fundamentally?
Coma results either from widespread diffuse damage or dysfunction of both cerebral hemispheres or from a focal lesion specifically disrupting the reticular activating system, RAS, in the brainstem, which is essential for maintaining wakefulness.
How do we assess the depth of coma?
The standard tool is the Glasgow Coma Scale, GCS,
Yeah.
which needs to be adapted for children, GCSP, who can't follow verbal commands in the same way. It scores eye-opening, verbal response, and motor response. A simpler bedside scale is AVPU, Alert, responds to voice, responds to pain, or unresponsive.
Can the physical exam beyond GCS help localize the problem causing the coma?
Yes, certain findings are very helpful. Respiratory patterns can give clues. For example, Cheyne-Stokes breathing, those cycles of deep breathing followed by apnea, often suggest damage relatively high up, and the diencephalon, thalamus-hypothalamus, or bilateral deep hemisphere dysfunction. Irregular patterns like apneustic breathing, pauses at full inspiration, or completely chaotic ataxic breathing point to damage lower down in the pons or medulla.
What about motor signs like posturing?
Posturing reflects brainstem involvement. As mentioned, decorticate posturing, arms flexed onto chest, legs extended, typically indicates damage above the red nucleus in the midbrain. Decerebrate posturing, arms extended and internally rotated, legs extended, suggests damage at or below the red nucleus, involving more of the upper brainstem. Flexidity is the worst sign, suggesting lower brainstem failure.
And pupils.
Pupil examination is vital. Small reactive pupils might suggest metabolic encephalopathy or diencephalic damage. Pinpoint pupils strongly suggest a pontine lesion, example hemorrhage or opioid effect. A unilateral fixed dilated pupil points towards uncal herniation compressing the third nerve. Bilateral fixed and dilated pupils are a very ominous sign, suggesting severe global damage or terminal brainstem failure. The reversible causes like drug effects must be excluded.
This leads us to the irreversible state. Brain death. The definition is strict. Complete irreversible cessation of all brain function, including the brainstem. What are the absolute prerequisites before you can even start testing for brain death?
This is critical. First, you must have an established irreversible cause for the coma that adequately explains the clinical picture. Second, you must rigorously exclude any potentially confounding factors that could mimic brain death but are reversible.
Such as
Core body temperature must be reasonably normal, usually above 32 degrees, some say 35 degrees C, as hypothermia suppresses brain function. Blood pressure must be adequate, normal for age. There should be no evidence of residual sedating drugs, anesthetics, or neuromuscular blocking agents. And severe metabolic disturbances like profound electrolyte abnormalities or hypoglycemia must be corrected. You have to be certain nothing reversible is causing the unresponsiveness.
Okay, prerequisites met. What clinical findings define brain death? What reflexes must be absent?
You need demonstrated coma, no motor response to pain except maybe spinal reflexes, and a complete absence of all brainstem reflexes. This includes no pupillary reflex, pupils fixed, usually midsize. No oculocephalic reflex, dolls maneuver eyes don't move relative to head.
Yeah.
No oculovestibular reflex, cold caloric test, no eye movement when cold water is put in the ear canal. No corneal reflex, no blink when cornea is touched. No jaw reflex, no gag reflex, touching back of throat. No cough reflex, suctioning the airway. In infants, sucking and rooting reflexes must also be absent. Everything mediated by the brainstem must be gone.
And the final confirmatory test, the apnea test.
The apnea test is essential to demonstrate the absence of the brainstem's drive to breathe. The patient is first pre-oxygenated well. Then they are disconnected from the ventilator while oxygen is still supplied, usually via a catheter in the airway. The clinicians watch closely for any respiratory effort while monitoring oxygen saturation and allowing the arterial carbon dioxide level, PO2, to rise.
How high does the CO2 need to get?
The test is considered positive, confirming apnea, only if no respiratory effort is observed when the patient No reaches a target level, typically 60 millimeter Hg or at least 20 millimeter Hg above the patient's baseline PaO2, whichever is higher. This confirms the medullary respiratory centers are not responding to the potent chemical stimulus of high CO2.
Now, a crucial point from our sources, the observation period required differs significantly based on age. Why the difference?
Yes, the guidelines mandate 2 separate clinical examinations confirming brain death, performed by independent physicians, separated by a specific observation period. This period varies by age, reflecting differences in brain maturation and potential for recovery.
How long for older children versus infants?
For children aged 1 year up to 18 years, the recommended observation period between the 2 exams is typically 12 hours. However, for term newborns, 37 weeks gestation up to 2 months of age, the required observation period is significantly longer, 48 hours. Periods for preterm infants, or those between 2 months and 1 year, vary slightly by guideline, but are generally longer than 12 hours.
48 hours for young infants versus 12 for older kids. Why such a big difference?
It reflects the clinical understanding and evidence that the immature infant brain may have increased resistance to certain types of damage and potentially a longer time frame for neurological stabilization, or rarely some degree of recovery compared to the more mature brain. It's an acknowledgement of the unique physiology and resilience and vulnerability of the developing nervous system, demanding greater caution and a longer period of certainty before declaring irreversibility. Hashtag tag outro. So we've really covered a vast territory today, from tracing the tempo of symptoms, that sudden strike of a stroke versus the slow creep of something like Gaucher disease, all the way to pinpointing the lesion anatomically using those and LMN signs or the cross paralysis pattern.
Yeah, and the mastery, as we said, isn't just listing conditions. It's about connecting the dots, right? Understanding why the GHAI virus needs pigs to keep its cycle going, or how meningomyelocele almost inevitably brings Carrie the second along with it, or realizing that getting the diet right for PKU or the copper chelation started for Wilson disease isn't just treatment. It's fundamentally altering the natural history of the disease.
Exactly. And it underscores the challenge and importance of precision medicine in this field.
Mm.
Early, accurate diagnosis is everything, especially for those conditions where we do have effective interventions. Think about treating status epilepticus within 5 minutes or getting those steroids in before the albendazole for neurocysticercosis. Those time-critical decisions, based on subtle patterns, define elite practice.
We finished by discussing the very strict, time-separated criteria for diagnosing brain death, and specifically that difference, the full 48-hour observation required for infants under 2 months, 4 times longer than for older children. It makes you think, what does that recognized extended resilience of the youngest brains truly tell us about the fundamental challenge of defining the absolute point of no return in pediatric neurology? What's the real weight of that extended observation period, and how does the unique capacity of the developing nervous system force us to grapple with the very definition of irreversible loss?
Oh.
That's the deep thought we'll leave you with this time. Join us for our next deep dive.